Hello and welcome. I'm Fred Loveland. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity titled Retooling for Modern Management of Progressive MS, an interactive case-based activity. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points, so make sure you engage in today's event, answer polling questions, and submit questions or provide your feedback. Once you completed today's program, be sure to provide your ABIM ID and birth date. In the evaluation, CME Outfitters will submit your MOC points. As I mentioned, I'm Dr. Fred Loveland. I'm the Saunders Family Professor of Neurology and Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at the Icahn School of Medicine at Mount Sinai in New York. I'm looking forward to our discussion today, which will focus on strategies for the diagnosis and treatment of patients with progressive multiple sclerosis. Let me introduce you to our faculty to join. Hello and welcome. I'm Fred Loveland. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity titled Retooling for Modern Management of Progressive MS, an interactive case-based activity. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points, so make sure you engage in today's event, answer polling questions, and submit questions or provide your feedback. Once you completed today's program, be sure to provide your ABIM ID and birth date. In the evaluation, CME Outfitters will submit your MOC points. As I mentioned, I'm Dr. Fred Loveland. I'm the Saunders Family Professor of Neurology and Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at the Icahn School of Medicine at Mount Sinai in New York. I'm looking forward to our discussion today, which will focus on strategies for the diagnosis and treatment of patients with progressive multiple sclerosis. Let me introduce you to our faculty that are joining me today. First, let me welcome Dr. Aaron Miller. Dr. Miller is Professor of Neurology and also the Medical Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis and the Vice Chair for Education at the Icahn School of Medicine at Mount Sinai in New York. Welcome, Aaron.
Nice to join you.
Also, let me introduce Dr. Claire Riley. Dr. Riley is an Assistant Professor of Neurology and the Medical Director of the Multiple Sclerosis Center at Columbia University in New York. Welcome, Claire.
Thank you, Fred.
As a reminder, the title for our program today is Retooling for Modern Management of Progressive MS, an interactive case-based activity. Let me review for you the learning objectives. First, to recognize the symptoms and clinical features of progressive MS. Our second learning objective is to summarize the immunopathology of progressive MS and the mechanism of actions of the new and investigational disease-modifying therapies. And finally, our third learning objective is to evaluate the latest clinical evidence of new and emerging therapies for secondary progressive MS and primary progressive MS, and engage patients in the shared decision-making process. Let me start with our first patient. Here is Andrew. In 2006, Andrew presents with numbness in his legs, Lhermitte's symptom, dizziness, and double vision. He was started on interferon beta-1a, and his symptoms resolved within 2 months. Over the next few years, he experienced several episodes of numbness in his legs. A 2012 MRI revealed many new small lesions. In 2014, he presented with a feeling of tight compression in his left mid-abdomen, weakness in his legs, and had to stop running a marathon after 5 minutes. The symptoms resolved, but new cervical spinal lesions were noted. In 2015, the patient's right foot was getting weak after exercise. He was limping after running 1 mile. In 2016, the patient was visibly limping and walking with obvious changes in his gait after 15 minutes of exercise. 6 months later, he was unable to go on walks for more than 30 minutes, even if he took a break, and he felt cognitively less sharp. His most recent MRI showed gadolinium-enhancing lesions. So here's our first of the polling questions. What is Andrew's most likely diagnosis? Clinically isolated syndrome, relapsing remitting multiple sclerosis, primary progressive multiple sclerosis, secondary progressive multiple sclerosis with activity, or there's insufficient data to attribute this to MS, or I don't know. Please answer now, and I'll share the results with you in just a little bit. Good. Okay. Aaron, let's start by talking about the different phenotypes of MS. Can you review the classifications for us?
Most MS starts out with relapses or exacerbations. So a clinically isolated syndrome is a person who presents with a typical episode of something that looks like it may be the first episode of MS. So a typical episode would be optic neuritis, a myelopathic picture with weakness in one or more limbs, or sensory abnormalities, or a brainstem or cerebellar syndrome. Because we have to satisfy criteria for dissemination in space and time to make a diagnosis of MS, we can't make that diagnosis in a patient with a single episode unless we get some particular help from the MRIs. MRI is very, very useful in making the diagnosis of MS, and the current criteria that we use, which are the 2017 version of the McDonald criteria, allow us to call something definite MS if the person presents with a clinically isolated syndrome, but the MRI shows both gadolinium-enhancing lesions and non-gadolinium-enhancing lesions, the latter implying remote disease and the GAD enhancement implying current disease. So that would meet criteria for dissemination in space and time. Once we allowed that MRI criteria, we greatly reduced the number of patients that we were labeling as clinically isolated syndrome. But still, there are quite a number of people in that category. The radiologically isolated syndrome is a fascinating entity, but it doesn't really belong in a list of phenotypes of MS because it's not MS. You're not entitled to call something MS if a person has never had clinical symptoms. The term refers to a person who has undergone an MRI for reasons not suspecting MS. In the US, that would be most typically a person with headache or somebody with a minor head injury. And then, lo and behold, on that MRI, you surprisingly find changes that are very characteristic of MS. But you can't call that MS until the patient subsequently develops some clinical manifestations. Now, relapsing remitting MS, which is about 85% of people initially diagnosed, these are people who have had at least one relapse and have satisfied dissemination in space and time. And again, you can use the MRI criteria as well as the clinical criteria to meet that categorization. Primary progressive MS refers to an individual who from the very beginning of the illness shows a gradually worsening disability, gradually progressive disability. Some of those people may subsequently go on to have active inflammatory activity, either in the form of a relapse or new MRI lesions, but we'll talk about that further later. And secondary progressive MS refers to an individual who had at least one relapse from which he or she either cleared those symptoms or at least plateaued and was stable for a period of time, and then later on starts to gradually worsen.
Right. Well, today we're concentrating on progressive MS. So could you tell us a bit about how the phenotypic descriptions have changed most recently?
Sure. So back in 1996, when you were involved in the first in a categorization of these phenotypes, we talked about three phenotypes: relapsing remitting MS, secondary progressive MS, which again was somebody who had relapses and gradually worsened after that, or primary progressive MS, somebody who was progressively worsening from the get-go. In a subsequent workshop that was sponsored by the International Clinical Trials Committee, supported by ECTRIMS and the National MS Society, these forms were modified. No change really in the criteria for relapsing remitting MS, but in all of these categories of disease, and we're going to focus on progressive disease in particular, you now have to modify that phenotype by making a determination of whether there has been activity, meaning a new relapse or new MRI lesions, and whether there has been progression in the recent past. But the important thing about all of those characterizations is you have to have a time frame. So by definition, everybody with secondary progressive MS had activity at one point. That's the way the term is defined. So when we talk about secondary progressive MS with activity, we have to put a time frame on. So typically, we may do annual MRIs. So we might say this patient has secondary progressive MS without activity, meaning we saw no relapses and no new MRI lesions in that period of time. Similarly, we can say there has or has not been progression during that period of time. And the same thing holds for primary progressive MS. We categorize that further into primary progressive MS with or without activity, and primary progressive MS with or without progression.
Right, so the primary progressive with activity now has subsumed what we used to call progressive relapsing MS.
Exactly, so we no longer use that term.
Right. Okay, so let's move on to diagnostic criteria. And Claire, would you run us through the current diagnostic criteria for primary progressive MS?
Sure. I mean, I think, Erin, you framed it very nicely, that, we've changed a bit the way we think about and characterize activity or no activity in progressive MS. But the brass tacks, if you want to enroll somebody in a study for primary progressive MS, what you need to identify is a year at least of disability progression. And that can be identified either prospectively as you're following them or retrospectively by the history. A lot of times I find that people describe first noticing symptoms just when they're tired or just when they're overheated, and then those symptoms, becoming more pervasive over the course of months or years. That's a typical kind of story that you'll hear. And then in terms of supporting evidence to make and support that diagnosis, two of the following criteria must be present. So either T2 hyperintense lesions in two of the four classic regions for multiple sclerosis: periventricular, infratentorial, cortical, or juxtacortical, and two or more T2 spinal hyperintensities, or CSF-specific oligoclonal bands. And interestingly, this was the year in this revision where oligoclonal bands reappeared in the relapsing remitting category as well. So I think there is, to some extent, CSF kind of making a resurgence here.
Right. So while iteratively the McDonald criteria have made it easier and easier to diagnose relapsing forms of MS, they maintain a certain rigor for primary progressive MS. The main reason is that's the form that's most likely to be misdiagnosed, either diagnosing primary progressive when it's something else or diagnosing something else when it's primary progressive. So one has to be very careful with that particular characterization. Claire, I want you to tell us a little bit. I'm going to do this. So I wanted to talk about this distinction between worsening and progression. We first discussed this in our Phenotype paper in 2014, and we've re-stressed it in a paper in neurology that's just gone online, a publication ahead of print, to differentiate the term so that everyone is using the same terms to characterize what goes on in multiple sclerosis, which is why we did the phenotypic descriptions in the first place. And so a patient with MS who's getting worse by either stepwise worsening from relapses that they don't recover from, or from progressive disease should be referred to as worsening. But we should limit the use of the term the patient is progressing only to those individuals who are in a progressive form of MS, primary progressive or secondary progressive, and are worsening independent of any relapse activity. And we think that's important just so we can be clear on what's going on with the patient. So worsening is a broader term. It's usual meaning the patient's getting worse by one of the mechanisms by which MS patients get worse. But progressing limited to only those worsening in a progressive phase of MS independent of relapse activity. Okay, let's move on and look at biomarkers. So Claire, tell us a little bit about what we can learn and what we can't learn from biomarkers.
Well, I'd love to say we had a perfect biomarker to predict MS progression, but unfortunately, at this point, there really are none. There's not one that's validated to really predict when people will progress. And I just really appreciate the clarification between progression and worsening, particularly since these are words that are in our vernacular speech that patients use all the time. I think that I hope that this paper is widely read and that the nomenclature is implemented, because I think that'd be very helpful. But in terms of predictors that MS is worsening, be that relapse mediated or gradual worsening, gradual or even progression, there are several candidate biomarkers that have gotten, interesting data is beginning to accrue. So radiographically, you can see brain lesions, T2 lesions that are atrophying, and that is associated with disease worsening. And you can see the rate of atrophy of the cervical cord, and that's looking at the cross-sectional area of the cervical cord usually. Neurofilament light chain levels can track with disease worsening and even seem to predict some degree of relapse activity, as well as disease worsening overall. And then, other candidate biomarkers include tau protein, the N-acetyl aspartate, chitinase, and osteopontin. But there's a lot more to learn here. I think that much more work to be done.
Yeah, and I think one of the points we wanted to stress that you've mentioned is that these are potential indicators of worsening, but not of defining secondary progressive MS. So let's shift to a look at disability progression. And I like this next slide because it helps put things into a time frame for us. So Aaron, why don't you take us through the time course of this patient?
So this is tracking one particular patient over time. And the important thing to note, which I'll go into in more detail, is that an individual patient, even in the progressive phase of the disease, can change and is not necessarily going to have the exact same phenotype at any given point in time. So over on the left-hand portion of this slide, you can see the curve of a characteristic relapse. Symptoms come on rapidly, typically over a couple of days or several days, may plateau briefly, and then the patient typically recovers. Maybe not completely, but often early in the course of the disease, the recovery is complete clinically. And then some time goes on, the patient is stable, and then in this particular illustration, the patient then starts to progress, and we see a sort of reddish bar here. And we're not seeing any new inflammatory activity in this patient during this period of time. In fact, the upward slanting arrows indicate times when MRIs were done and no new activity was, well, actually this patient, I'll take that back, indicates there was MRI activity. So even though the patient appeared to be progressing gradually, there was superimposed activity. The time axis, the x-axis here doesn't indicate what exactly the time frame is, but let's say that you would have seen that patient shortly after the middle arrow, you would have said this patient has secondary progressive MS with activity and with progression. Then the patient had a superimposed relapse, which is another form of activity, and again showed some improvement before taking on resuming his or her inexorable progressive course. And as indicated in the green portion of this curve, now there are either no MRIs obtained or there was no MRI activity. The patient is gradually progressing, so we'd call this now secondary progressive MS without activity, but with progression. And then the light blue portion of this curve indicates that these patients can plateau and stabilize. And this patient would have secondary progressive MS based on the prior course, but you would now say this patient has secondary progressive MS without activity and without progression. And then once again, he had new MRI activity, and so he would have been secondary progressive MS with activity.
Good. Okay. So Claire, tell us a bit about the role of MRI screening in clinical diagnosis and monitoring in multiple sclerosis.
Sure. So and the lowest hanging fruit is really lesions. So even just going for the name, multiple sclerosis, many scars, right? We're referring here to sort of the distinctive pathologic and radiographic white matter lesions. We have characteristic locations, some of which I mentioned earlier, periventricular, juxtacortical. We see these in the spinal cord as well. And these are sort of, if you had to choose one thing, I think to see, you probably want to know what was happening with lesion volume, number, and activity. So are they active or not active? But especially for research purposes and monitoring response to therapies, I think we're getting into a more complicated landscape in MRI. Cortical lesions now have made their way into the McDonald criteria. We know that the lesions of MS are not strictly white matter lesions, that they're present in cortex, that these do seem to associate significantly with clinical disability and also cognitive impairment, which is a major issue for people with MS, sometimes under-recognized. And these cortical lesions are also associated with inflammation in the meninges. And then leptomeningeal infiltrate. So this has been an interesting area of research, particularly using high field MRI and post-contrast FLAIR, where we can see these infiltrates in the leptomeninges. And I think these have, interesting implications for thinking about therapies particularly for progressive MS. And then normal appearing white matter and gray matter, even though it may look normal to on a standard sequence on an MRI, there are new radiographic techniques that may help us monitor these changes in myelin that can happen. For example, with MTR, one can see changes in myelin that otherwise appears normal. And in terms of normal appearing gray matter, the volumetrics really matter. So even in RIS, not even yet a diagnosis of MS, but even CIS, you can see thalamic and deep gray structural atrophy that can predict cognitive impairment and to some extent some outcomes. So I think there's a very important role for imaging, both on the clinical management side and in research and clinical trials.
Good, thanks. So before we go on to the polling question, I want to answer a question that's come in online from one of our attendees. And that the question is, in terms of progression time, are there any distinct differences between primary and secondary progressive MS? Aaron, what do you think? Rate of progression.
I don't think we have any data that says that that either one of those progressive phenotypes is going to progress at a different rate on average than the other. I'm not sure, frankly, that the question's been looked at really, but there's a lot of variability in the progression rate. I have patients that I've diagnosed with primary progressive MS who've then been stable or so slowly progressive I can barely see a change over years. And then we see some patients with either primary progressive MS or secondary progressive MS who sadly have a very rapid decline.
So this is something that we took up this issue when we were doing the phenotypes, because the question was raised, well, is primary progressive MS part of the spectrum of MS or is it different? And as you can tell, we concluded that it was part of the spectrum of MS, but there are some differences, even between primary and secondary. Although the ages at which people start to progress are fairly similar, secondary progressive MS demographically looks like relapsing remitting MS with more women involved than men, whereas primary progressive has about equal numbers of men and women. Immunologically, genetically, you can't distinguish between them. And many of us think that progressive MS is progressive MS, whether it starts out with relapses or not, that once you enter that phase, the underlying pathophysiology is the same, but we've not yet proven that. So it's an interesting issue. So there are ways, and there have been studies that have combined both in one trial, and other times people separate them out. And we need to get some more clinical trial data to better answer the question of how are they similar and how are they distinct. Okay, let's go on to our polling question again. Now, here it is again. So what is Andrew's most likely diagnosis? Clinically isolated syndrome, relapsing remitting multiple sclerosis, primary progressive multiple sclerosis, secondary progressive multiple sclerosis with activity, or there is insufficient data to attribute this to MS, or I don't know. So let's answer that and then we'll look at the results. Okay, dark blue is before and sort of chartreuse is after. And secondary progressive with activity got the most votes, although not all. Claire, what do you think?
I think secondary progressive with activity. So he had an enhancing lesion. Hard to argue otherwise.
And he was gradually progressing. Right, so this wouldn't be primary progressive because he started out with relapses. Okay. Now let's talk a little bit about the pathogenesis of progressive MS. Aaron, what are some of the mechanisms involved in development and progression of MS?
So relapsing MS is characterized by very prominent inflammation with predominantly T lymphocytes, but also B lymphocytes involved in these active inflammatory lesions. That's what's responsible for the gadolinium enhancement. There's breakdown of the blood-brain barrier and leakage with edema surrounding the lesions, and usually perivenular cuffs of lymphocytes often seen. The pathogenesis of MS, of progressive MS, is felt to be quite different. There still is inflammation, but it doesn't look like the inflammation that we see in relapsing MS. And it's felt to occur behind a more intact blood-brain barrier, and those inflammatory changes are often compartmentalized. For example, in relatively recent years, it's been found that there are B cells often clustered in the meninges, often sometimes looking like lymphoid follicles. But we don't see the really active inflammatory lesions that you see in relapsing MS. The other characteristic thing is that there is microglial and macrophage inflammation, activation. Macrophages coming from invading monocytes and microglia being resident in the central nervous system. But these both proliferate and become active, and they secrete a lot of cytokines, which may be part of the reason there is progressive axonal destruction in progressive forms of MS. Cortical demyelination is extensive in progressive forms of MS. And although you can detect it pathologically in relapsing forms, it's very difficult to discern on MRI, no matter what stage of the illness. But if you were to look at pathologic specimens, one sees an extensive amount of cortical demyelination. And part of this may occur from an outside-in pathological process. Remember, I mentioned that there are B cell collections in the extra CNS space and within the meninges, and these collections may potentially secrete cytokines which cause this subpeel demyelination. So we often see loss of myelin right near the peel surface. So other changes that we can see relate to oxidative injury, which often involves mitochondrial damage. In people with progressive forms of MS, there seems to be a greater energy demand, and the brain and the mitochondria, which are often injured, cannot keep up with that process, which results in further damage to the axons. Myelin itself is protective of axons, and when axons lose their myelin coating, they become much more subject to destruction. Many of the changes in progressive disease include the deposition of iron in various parts of the brain, and there's also evidence of glutamate excitotoxicity. Furthermore, astrocytes can become activated, and these ubiquitous cells in the central nervous system themselves could potentially be secreting substances which are damaging to axons. So overall, there are a lot of factors in play here. The respective roles of each of these is uncertain, but they do give us a lot of potential targets to treat progressive MS with which up till now we've been unsuccessful.
So let's take a look at those targets.
So as I mentioned, B cells are a prominent player in progressive MS. These follicles are mainly seen in secondary progressive MS and in more chronic and more advanced cases. But we know already that there's at least one anti-B cell therapy, ocrelizumab, which we'll talk about later, which has had a benefit in primary progressive MS. I don't believe it's been studied in secondary progressive MS. And although T lymphocyte infiltration is less evident in progressive forms of MS, there still appears to be some role for that. As I mentioned, the mitochondria appear to be injured in progressive forms of MS. So if we could find a way to protect those mitochondria, perhaps from the damage by free oxygen radicals, that might be helpful if we can prevent oxidative injury. Anti-inflammatory strategies still play a role. And if we could find ways to remyelinate, that would be very helpful. We know that the brain has the potential to remyelinate, but it varies from plaque to plaque. It varies from individual to individual, and it's never complete. And it appears there are barriers to remyelination that are intrinsic to the central nervous system. If we could overcome those barriers, we probably could ameliorate some of the damage.
So we have a question that's come in from one of our attendees asking about remyelination. And so the question is, do our treatments have a role in remyelination?
So I don't believe the current treatments have been found experimentally or demonstrated in humans to actually bring about remyelination. We do, of course, have problems in studying remyelination in humans because we don't really have adequate ways to look at that. But we do know that with the highly efficacious therapies that we have now, a lot of patients improve. So why they improve is unclear. It could be that they're remyelinating from the effect of the drug, but that seems relatively unlikely because it happens with drugs that don't even get into the central nervous system. My view of this is that if you create a milieu in which you tamp down active inflammation, you may allow the brain to go through its usual steps of remyelinating more efficiently, and that may bring about improvement.
And we have some experimental approaches underway, which may enhance remyelination. So, okay, good. So let's move on. Let's go back to our case of Andrew. Remember, he was diagnosed in 2006 and was treated with interferon. Recently, he's had issues with gait and cognition. So what class of therapy would you treat him with? An immunomodulator, cell trafficking inhibition agent, a cell depleting therapy, or I don't know? So go ahead and answer this, and I'll share the results with you in a little bit. So I suspect that not everyone was familiar with these particular characterizations of the therapy. So Claire, why don't you take us through these?
Sure, happy to. So the immunomodulators include some of the older injectable therapies, the interferon beta molecules, glatiramer acetate, as well as some of the oral agents, dimethyl fumarate and the newer diroximel fumarate, a pretty similar medication, as well as teriflunomide. And what these agents share is what I would describe as sort of modest to moderate efficacy in terms of diminishing the likelihood of a relapse in a relapsing patient or a patient with activity or radiographic disease activity. Each has been used for a relatively long time. Dimethyl fumarate and diroximel fumarate were approved later, dimethyl in 2013 and diroximel just in the last year, but are related to fumaric acid derivatives that have been used in the treatment, for example, of psoriasis and other inflammatory and autoimmune disease. And then teriflunomide is pretty closely related to leflunomide, which has been used for rheumatoid arthritis for some years. So in general, they tend to provide a pretty robust safety profile, but relatively modest efficacy. Some are injectable, which can be burdensome for patients, and also have some tolerability issues, particularly GI tolerability with the fumaric acids. And then the cell trafficking inhibition agents are agents that all in different ways interfere with the movement of lymphocytes. And two main classes here would be natalizumab and a class of its own. It is a molecule that blocks the migration of lymphocytes across the blood-brain barrier by blocking their adhesion to that endothelium. And that is an agent that's high efficacy for relapsing MS and has been studied in secondary progressive MS. I think many believe that had that study gone on a bit longer, or had a more modern adaptive design, perhaps that would have shown some benefit. And it has, as part of the FDA's great sort of reworking of the labels, been now labeled for secondary progressive MS with activity. And then the S1P class, which subsumes all the other agents listed here. So this is essentially molecules that block lymphocyte egress from the peripheral lymph nodes. So you see, profound depletion, or relatively impressive depletion, at least, of circulating lymphocytes, though they are still, participating in immunologic cascades from their sort of lymph node prison, if you will. So what are the benefits of these agents? They have high efficacy in terms of moderate to high efficacy, I would say, in reducing relapses and inflammatory disease on MRI, as well as borne out in relapses. They tend to work relatively quickly and are well tolerated in general. Natalizumab is infused typically every 4 weeks, although there is research going on now to evaluate extending that dosing interval, perhaps out to 6 or 8 weeks. Downsides of these agents are opportunistic infections, including PML, though I'll mention we have seen PML with dimethyl fumarate as well. And then the potential for rebound disease activity, so if you have there's sort of the barbarians at the gate concept. So you put these lymphocytes behind a barrier, and then you take down that barrier. You may see sort of overly exuberant disease activity when access is restored. So that can be problematic and I think requires attention when transitioning to a different therapy. And the long-term safety is an issue. So, we do have pretty well characterized risk profiles. So particularly looking at PML for natalizumab, we know to monitor for JC virus antibody. We have some thoughts about how to mitigate risk, perhaps by extending the dosing interval, but there could be other other issues not yet known. And then in the cell depleting therapy class, we have several agents. So alemtuzumab is a very infrequently administered monoclonal antibody that depletes broadly B and T lymphocytes with a gradual return of each. Cladribine is short course oral therapy, also given intermittently, and causes, sort of broad suppression as well. And that is by actually intercalating into DNA. Ocrelizumab, rituximab, and ofatumumab, which is in front of the FDA right now, all are B-cell agents. Rituximab, I mentioned, is widely used, I would say, for multiple sclerosis, both in the United States and globally, but is not FDA approved for MS. But each is a monoclonal antibody directed against a mature B cell. And then bone marrow transplant or hematopoietic stem cell transplant would be sort of the ultimate cell depleting therapy. Now, pros of these is that they're highly effective. Some are really immune reconstitution treatments. So you see, the immune system really pretty profoundly suppressed and returning in a different form. They have a gradual offset and don't show that kind of robust return of inflammatory activity in my experience and supported in the literature. Potential downsides, we can see opportunistic infections, particularly with alemtuzumab. We've seen secondary autoimmunity. About a third of people will develop some secondary autoimmune phenomenon. And in terms of cumbersome, I would say they require a fair amount of monitoring, though the B-cell therapies, given intermittently, and we have yet to really experience ofatumumab, but the expectation is that would be a subcutaneous self-injection. So that may actually provide flexibility for people who find it cumbersome to come into an infusion center. So I would say it's sort of a mixed bag in terms of ease. But those are the big categories. And as I said, sort of the FDA sort of relabeled each of these agents for secondary progression with activity, with the exception of a few agents we'll talk about in a moment who actually had dedicated clinical trials in progressive MS.
So before we move on to that, you mentioned this, but since someone asked the question when looking at this particular slide about rituximab. So rituximab, as you mentioned, is not approved for treatment of MS. It is approved by the FDA for other indications, but it is widely used worldwide as a treatment for MS under the same logic of B-cell depletion. Okay, let's move into the progressive MS therapeutic landscape. And Claire, go through our options here.
Yeah, I mean, these are the same usual suspects that you saw on the prior slide. The big distinction here is that there was an explicit study in primary progressive MS, the Oratorio trial with ocrelizumab, and so it is the only agent that is labeled for primary progressive MS. And then we see, the whole menu here of secondary progressive MS with activity. And that includes agents in each of those classes that we discussed, from the first agents approved for MS, interferon beta, 1A, 1B, pegylated interferon, glitiramer, and then the oral therapies that I mentioned, as well as the infusible and monoclonal antibodies, and perhaps in the next several months, ofatumumab, which is also a monoclonal antibody.
So this is an interesting situation because if you look at that list of secondary progressive MS activity, only two agents in that list were ever studied in secondary progressive MS. So natalizumab that you mentioned did not have a successful trial. And siponimod, which only studies secondary progressive MS and had a modestly successful and statistically significant result. But then they went ahead and gave this broader labeling to all the agents. And one of the problems with which Aaron Miller kind of stressed earlier was the labeling does not provide any time framing. And so theoretically, as Aaron had said, any secondary progressive patient had activity at some point, which is why when we came out with these characterizations, and we stressed this again in the recent neurology publication, it's just gone online, that activity has to be framed in time. You could take 1 year, you could take 2 years, take 6 months, but you have to frame it in time. And this was an issue with what the regulators did here. And when they were talking about activity, they were only talking about relapses. In Europe, the regulators similarly did not time frame the activity, but they did include MRI activity in their descriptions. So that's caused some confusion, although it makes it somewhat easier for clinicians to prescribe medications. And we hope it does not cause confusion and difficulty with pharmacy benefit providers and insurance. Okay, so Claire, let's talk about some of the recently approved therapies and what the clinical trials have shown.
So as I mentioned, Oratorio is a dedicated clinical trial in primary progressive MS. It was done sort of in parallel with the large relapsing remitting program of clinical trials for ocrelizumab, OPERA 1 and 2. And the important outcome here, I believe, was this reduction in the rate of 3-month confirmed disability progression. And that was a 24% relative risk reduction. The numbers aren't huge, 39% progressed on placebo, 33% with ocrelizumab, but it was consistent. I mean, you can see those lines really did diverge. And that was supported by changes in T2 lesion burden, where we actually saw a reduction in the T2 lesion burden from baseline in the ocrelizumab group and an increase in T2 lesion burden in the placebo group over the course of the study, which had ran over, let's say, almost 3 years.
Okay, now let's take a look at siponimod. We talked a little bit about this already.
Yes, so I would say that siponimod and the EXPAND trial has sort of led the charge for secondary progressive and the MS and the consideration of agents with kind of these mechanisms for approval in secondary progressive MS. So this was a large study, 1,651 patients. And again, this outcome of 3-month confirmed disability progression was reduced to 26% versus 32% for patients who are on siponimod. So a 21% relative risk reduction, and also supported by the radiographic data. Okay, and cladribine. And I think this is very interesting. So it's sort of, new wine in old bottles. Cladribine, if this study's design feels a little bit older, it's because it was. So this actually, you can see the date was published in 2010 and was a study of about 1,300 patients. Cladribine versus placebo, and showed a 33% relative risk reduction, and again that 3-month confirmed EDSS progression. And there was a change in the number of active T2 lesions per scan. But I think this was a relapsing remitting study, but it had a relatively high EDSS, and I think this is this and the EDSS progression data, just with a relatively high EDSS population. It became under the lens as almost a secondary progressive study, and a slightly older population, higher disability. Okay, and let's move on to not yet approved. Aaron, tell us a little bit about what we know about ofatumumab.
So ofatumumab is, as you said, it's the horse waiting to get out of the barn. It's not yet approved, but the data has been published, and this is another anti-CD20 agent like rituximab and ocrelizumab. Each one of these agents is slightly different. They attack different portions of the CD20 molecule. The mechanism for getting rid of those CD20 positive cells may be different among the respective agents, but they've all been pretty comparably effective. Now, as you know, in generally speaking, it's not legitimate to compare the results of studies across studies. To compare the relative effectiveness of one drug to another, you have to study them in the same trial. And that, of course, hasn't been done among any of these B-cell therapies. And in particular, it's difficult to compare the results with ofatumumab to that of ocrelizumab, because both of these studies were done with active comparators, because it's, at least in the relapsing remitting population, which is where ofatumumab has been studied, it was not considered ethical to do a phase 3 trial utilizing placebo as the control arm. So there were active comparators, but the drugs that these respective agents were compared with were different. In the ocrelizumab study, the comparative agent was an interferon administered 3 times a week. And in the ofatumumab study, the comparator was teriflunomide. Nonetheless, these drugs had a very, very major effect on relapsing remitting activity and on MRI activity. But we're focused here on the progressive data, and we see that with ofatumumab, the disability progression was a little under 11% compared to 15% with teriflunomide, showing a little bit more than a third relative risk reduction in favor of ofatumumab. That 15% reduction with teriflunomide, by the way, probably implies that there is an effect on progression with that agent, which was indeed what was seen with the teriflunomide relapsing remitting trials. There was also a significant reduction, a very significant reduction in MRI activity with ofatumumab. So as Claire mentioned, this drug is given subcutaneously once a month in comparison to ocrelizumab, which is administered by intravenous infusion every 6 months. And it will remain to be seen whether patients and providers will have a preference for one route and frequency of administration over the other.
So to be clear here, this is disability worsening, right? So ofatumumab hasn't been looked at in a progressive population.
Correct.
So this is measuring disability change, which either could be to progression independent of relapses or worsening from relapses. And that's why they've used the term CDW instead of CDP. So I prefer disability worsening. Okay. Now let's move on. What class of therapy would you treat Andrew with? You've answered this before, you could answer it again. Immunomodulator, cell trafficking inhibition agents, cell depleting therapies, or I don't know. Let's see how the answers stack up. Okay, so the majority here are going for a cell depleting therapies, and next to cell trafficking inhibition agents. So, Aaron, Claire, any comments about this?
Yeah, so again, this is a patient we categorized as having secondary progressive MS with activity. I fully agree with Claire on that. And so many drugs, as you saw that long list that Claire offered, would be consistent with the prescribing information. The only drug that's specifically been tested in the secondary progressive population, albeit not requiring activity, was siponimod. So that would be certainly a reasonable choice, as it garnered approval only for secondary progressive MS with activity. On the other hand, if you look at activity per se, most MS specialists would probably feel that the cell depleting therapies are more effective on inflammatory activity, not necessarily so on progression. So I think either of those categories would be reasonable choices in here.
Okay, Claire, anything you want to add?
Yeah, I agree. I mean, I was just trying to look back to see if we knew how old he was in terms of thinking about, risk of some of our cell depleting agents. I don't see that in our description, but I think that it is a balance of potential benefit and potential risk. I mean, this guy is clearly having worsening. He has activity. I would be certainly talk to him about probably B cell therapies, S1P agents as options, and potentially natalizumab if he were JC virus antibody negative. I think that could be something to try as well. So I think he has quite a few options, and I think knowing that he'd previously been on interferon beta and had disease activity throughout that, I would not use interferon beta. But you could, you wouldn't necessarily be wrong by choosing, teriflunomide or one of the other orals, and it's sort of a balance.
Okay, let's go on to our next case. This is Mary, 45-year-old individual with endometriosis, but otherwise healthy. In 2013, Mary developed left optic neuritis, and her brain MRI showed multiple white matter lesions, and she was prescribed interferon beta 1A. In 2014, she began to drag her right leg and reported difficulty walking long distances because of weakness and fatigue. Her symptoms improved, but did not resolve completely. Mary continued to report episodes of worsening balance, unsteady gait, and lower extremity weakness, and began using a cane intermittently in 2016 and regularly in 2017. She did not return for appointments until 2020, where a neurological examination found moderately severe spastic paraparesis, mild dysmetria, clumsy rapid alternating movements in her arms. Her most recent MRI in 2020 showed non-enhancing lesions compared to the prior MRI in 2010. So let me ask the audience, what class of therapy would you treat Mary with? An immunomodulator, cell trafficking inhibition agent, cell depleting therapies, or I don't know? And we'll come back to your answers in just a little bit. So now we want to talk about treatment decisions and how to make them and how optimally to make them. And Aaron, why don't you talk a little bit about the considerations that are at play when deciding benefits and risks?
So without question, there's not a story here of one size fits all. The choice of a disease-modifying therapy for an individual patient has to take into consideration many factors, some properties of the therapy itself, some properties of the patient's tolerance for risk and need to achieve great benefit, and some psychosocial factors. Pregnancy, of course, is a very important consideration for a number of women who are contemplating having a baby. But people differ in how much risk they're willing to take. So some of our older drugs are on average less efficacious, but they have very, very little risk. They're extremely safe. In general, though this is not entirely true, but in general, our newer agents, which have greater efficacy, also entail greater risk. So you have to have a conversation with the patient and talk about that balance. Lifestyle issues could be important. Some patients find it very intrusive on their life to go off for regular infusions. Some patients absolutely hate the notion of having an injectable therapy and only want to have an oral drug. Other patients love the idea that they might take something very infrequently and be able to forget about their MS, hopefully on a daily basis, not be reminded by the need to take pills. So there's a lot to discuss, and that's why I strongly believe in shared decision making.
So take us through the strategies here.
So again, I think choosing a drug for a particular patient requires having a dialogue. And I actually never do that the first time I see a patient. If I have a newly diagnosed patient, it's going to be an entirely separate visit in which I talk about the disease-modifying therapies. I would say on average, that conversation takes about 45 minutes. And then we're going to have a dialogue. I'm going to watch how the patient reacts to various things. I'm going to give that person an opportunity to answer questions. And importantly, I'm going to watch the body language. I'm going to watch the eyebrow going up when I talk about certain therapies. And I'm going to see the look of fear if I mention certain side effects. And then, so the important thing is to communicate the information that we know in a very truthful manner, but in a way that the patient is able to understand, and promote their asking questions and engaging in a dialogue so we can reach a common ground that we're happy with.
So you kind of talked about this engagement of patients, but go through it a little more for us, please.
Yeah, so again, lifestyle issues are important. Patient's occupation might be important, again, in limiting what their time schedule is, what their ability to tolerate side effects is. In the old days, for instance, when we used a lot of interferons and most patients were feeling very uncomfortable on the day after their shots with flu-like symptoms, that would be an important consideration. One of our drugs, for example, produces flushing, which can be prominent in some patients. That could be an embarrassment at work if a patient has a public-facing job. So these are important considerations. Vaccinations, sometimes patients need to be, we need to make sure certain vaccinations, particularly for varicella, are done in advance of the initiation of some therapies. We're still gathering data on how some of these drugs impact the response to vaccinations. That's, I think, come into play in our thinking now more than ever, because as we try to develop a coronavirus vaccine against SARS-CoV-2, we're wondering, will some of these drugs impact the responsivity to that vaccination once we get it? I've already mentioned about pregnancy, and I think the medication-related considerations you see here. So it comes down to a risk versus benefit conversation and the ability of or willingness of a patient to tolerate certain side effects. There's no free ride with any medication that we prescribe in medicine.
So what resources do we have?
So there are a number of things that you might be able to utilize to help patients understand their MS better. My colleague at Mount Sinai, Dr. Stephen Krieger, has developed a very useful teaching tool, and that's available as an app. It's his MS topography app, in which he envisions MS like a swimming pool with a deep end and a shallow end, and the shallow end representing a loss of brain or central nervous system reserves, and a tendency for things to sort of icebergs to come up above the surface of that water under certain circumstances when that reserve declines, and that's when we may see clinical activity. So that's a helpful tool to help patients understand the conversation if you choose to use it. There are a number of available instruments that you can pick up from the web that are decision aids. One of them is called the 9-item shared decision-making questionnaire. I must confess that I personally don't use any of these tools. I'd rather use my own words and my own descriptions. And maybe having done this for more than a few years, I feel particularly comfortable in doing that.
Yeah, understood. Okay, let's go back to Mary. Remember, she did not come into our appointments for a number of years. When she finally did come in, she had new T2 lesions. She would prefer not to have infusions. How would you treat Mary now? Immunomodulator, cell trafficking inhibition agents, cell depleting therapies, or I don't know? Okay, so the before referred cell depleting therapies, and the after is cell traffic inhibition agents. So Claire, talk about these choices based on what we know about Mary.
Well, I think that the biggest characteristic of Mary is that she's had a progression, gradual worsening, it seems, and we don't know how recently she had really activity. We know she has some new T2 lesions since her last MRI, but that was several years prior. So, and this is a very common clinical scenario. I think that we all see this, and some of it may reflect some of our own nihilism or the lack of therapeutic options that make patients frustrated and lead to, inconsistent follow-up. So I would say that she would fit pretty well into sort of the expand clinical trial, and I think she'd be a good candidate to try an S1P modulator. I think, you would want to choose someone who didn't have, cardiac rhythm issues probably, or significant comorbidities, cardiac comorbidities, given that mechanism. And she's otherwise healthy. So I think I would agree with our esteemed audience here. I think you could also consider cell depleting therapies in her, but yeah, I think that makes a lot of sense. And she prefers, not to take an infusion-based agent. So then among the cell depleting therapies, I guess cladribine could be considered. And it's not an agent that we've had for a very long time in this country. So my overall experience with cladribine is somewhat limited, but I think it could be a good application for that agent as well.
I would second that, Claire, as a useful option, given that she didn't want an infusion therapy, because this is a woman with a history of non-adherence to the medical regimen. I don't know exactly how diligent she was about taking her prior therapies, but we know that she's disappeared for 2.5 or 3 years. She hasn't had MRIs for years, so it might be attractive to be able to give her an annual cycle of cladribine that we then only have to repeat a year later, and
that's a good point. And then you wouldn't have to worry about the kind of monitoring that you'd need to do with an S1P modulator, like annual dermatology evaluation, making sure she got to the ophthalmologist, all those things. I mean, I think that's a very good point.
Okay, excellent. So let's summarize where we are. And we're recommending SMART goals: specific, measurable, attainable, relevant, and timely. So combine diagnostic features and the clinical picture to diagnose progressive MS. Integrate the most recent clinical data and mechanism of action of novel and available therapeutic agents into treatment paradigm for patients with progressive MS. And we want to engage patients in the treatment decision-making process. So I already have lots of questions, but please send in your questions now, because we're going to go over them moving forward. And we still have time to get to these. So one of them is, Claire, do oral therapies have slower onset of action?
By and large, I would say yes. I would say that, my expectation is for teriflunomide, dimethylfumarate, diroximel fumarate, as well as the S1Ps, to really start working in the 3 to 6 month range. Whereas I'd have to look back at some of the studies that have done interval imaging. I think the first that we've seen with ocrelizumab, I think was at the 3-month interval, but jump in if you recall otherwise. But that efficacy perhaps with natalizumab or ocrelizumab, we might expect a bit sooner.
Okay, and Aaron, concerns with COVID and avoiding cell depleting therapies?
Yeah, so there's a lot of work going on around the world to try to understand whether any of the disease modifying therapies has any particular added risk, probably more so for the question of the severity of the SARS-CoV-2 infection if you do get infected, rather than the added risk of getting the infection. We simply don't yet have enough data about that, but there are large registries throughout the world, big registry collection by the MS International Federation. The National MS Society here in the US has a registry called COVI-MS, and I would encourage any of you who have MS patients, you can go and log in. It takes about 10 minutes to enter a patient. We need to get that data. But so far, we have not identified an added risk with any of the particular agents. I would say that I think there is a level of concern about the B-cell depleting therapies that rises above that with most of the other therapies, but we still need to see some data.
But thus far, anecdotally, our experience with ocrelizumab has actually been pretty good. It looks very similar to those not on any therapy at all, but that's still anecdote. Claire, any experience uptown?
I would say that I have, more of a hypothetical concern in agents, potentially cladribine, alemtuzumab, that have more broad suppression, including any suppression of CD8 cells, that those might impact an individual's ability to respond to the COVID infection. We've definitely had a lot of patients acquire COVID, and vast majority have recovered, but it is not been ubiquitous. I would say that those who had severe disease did generally have other comorbidities, and as we think about metabolic health and controlling other risk factors, those are good for MS too. So I think that is a good goal anyway. I am pretty concerned, though, about the B-cell therapies and how they may impact an individual's ability to develop long-lasting antibodies that may hopefully confer immunity to the virus. We've had quite a few patients who had a definite COVID syndrome, were PCR positive, and now a couple of months later are not developing or don't have detectable antibodies. So I think that this is a concern, and I think we as a community need to think about how to approach vaccination in this community.
Yeah, that's going to be important for us to look at for all of the therapies. Okay, so another question: do you use MRI atrophy to monitor a patient? If so, how much atrophy would you allow before changing a treatment? I'll give it to you both, but Claire, why don't you start?
We're not measuring it systematically. I would say I do measure third ventricular width in people when it catches my eye, and that's sort of a non-scientific answer, but I will track that, especially when people seem to be having disability worsening in the absence of inflammatory activity, at least something to track. But no, we're not, doing systematic measurements.
Yeah, I would echo that. There are some, on the routine commercial MRIs that we obtain, you don't get measurements of atrophy. Of course, you can eyeball and see the obvious atrophies, but otherwise it's not calculated. There are a number of software programs that proprietary companies have and will sell to various imaging centers that can quantitate that. My own view is that I don't think we have enough data at an individual level to say that a certain degree of atrophy or a certain rate of atrophy is going to predict what's going to happen over the relatively near term or should guide our therapies, especially since we really don't have therapies that have been identified to be particularly helpful for progressive forms of MS without activity, with the exception of ocrelizumab in primary progressive MS.
So as a follow-up to that, the question here is, how are clinicians supposed to monitor their patients while on these newer therapies?
Yeah, so that's a challenge. And in fact, I talk to patients about that. this is true for relapsing remitting MS as well, but it's particularly important for progressive MS that the patients understand that it's very, very difficult to assess whether the drug is working. Because a lot of times patients with progressive MS will worsen in a fairly indolent fashion, a fairly slow fashion, and sometimes plateau. So if they're not clearly progressing, we'd like to give credit to the medication, but we don't really know that that's the case. Conversely, if they are continuing to show some slow rate of progression, but we're not seeing new inflammatory activity on the imaging and they're not having relapses, we don't know that the drug has not been damping down the rate of progression. So I tell patients that to a certain extent, they have to go on these drugs and take an act of faith. We're going to monitor them clinically. We're going to look at their MRs, but it's going to be very difficult at times for us to know for sure what the drug is doing.
Okay, along similar lines, is 3-month confirmed disability worsening adequate as an outcome measure for progressive MS?
Well, so a lot of studies have looked at both 3-month confirmed worsening and 6-month confirmed worsening. I think the advantage of looking at 6-month confirmed worsening is that you're much less likely to be dealing with a phenomenon that has been caused by active inflammation, even though we may not have seen the GAD enhancement or we may not have picked up a relapse. Nonetheless, a lot of relapses take longer than 3 months to recover, so we may still be in a window where the 6-month time frame gives a range. Nonetheless, I think 3-month worsening is a pretty good through a confirmed 3-month worsening. That's the important thing to emphasize, is that you see the worsening at one visit and then you have to come back 3 months later. It's not that the patient has gotten worse in a 3-month time frame.
And so there's another concept here, and that is sustained disability worsening. And there, the individual not only has to have the worsening confirmed at 3 or 6 months, but it can never get better. So at the end of the study, they're still at that level or worse. And that was one of the outcome measures in the natalizumab secondary progressive trial, which Claire Wiley mentioned, that was unsuccessful. But that's an outcome that makes perfect sense for looking at progressive disease, because they shouldn't go back. Okay,
it's so tricky, though, I find. I mean, many patients will fluctuate through the course of the day from season to season. They're affected by humidity, by heat, by sleep and mood. I mean, I just think that there's so many challenges. I wonder, in terms of clinical trial methodology, if we could integrate in the future something that, as a wearable device that actually captures how much they're moving, or their natural gait when they're not in the office under the microscope. I think that there are just so many ways that the particular day of the visit or day of the study measurement can confound things.
Okay, Aaron, do you think resident non-circulating lymphocytes are important for the propagation of MS disease? And if so, how do we attack them?
So I'm probably not enough of an immunologist to actually answer this question with any degree of validity. But I think, assuming that were the case, and it's quite probable that that certain populations of lymphocytes that are within the central nervous system may be doing damage. And in order to attack them, presumably the first thing we have to do is to be able to get the agent that we want to attack them with into the central nervous system, which probably generally is going to imply a small molecule. But I think there's a lot of work still to be done on this whole concept.
And the idea of trying to hit some of the innate markers as well, macrophages and microglia. But right. Really, it would take something that crosses the blood-brain barrier and gets into the central nervous system.
Well, the other way to get in, right, is to put it in. So we had that the study at the NIH with intrathecal as well as intravenous administration of rituximab, and that, you know, I was very interested in that as an approach. Not successful, but I think an interesting idea.
Yeah, the intrathecal didn't produce a benefit. Okay, what is the likelihood that a person with progressive MS is diagnosed with another disorder such as lupus or NMO? And how would that impact their MS treatment, prognosis, and the course of their disorder?
Well, I can tackle that. So, first of all, let me just say in general, misdiagnosis in MS is a big problem. Um, and that goes for both relapsing forms of the disease and progressive forms of the disease. And that's why the diagnostic criteria, the McDonald currently 2017 criteria, are so important to apply properly. NMO, however, is not a problem here because NMO essentially never or virtually never produces a progressive course. Here's a case where people do indeed get worsening from the disease, but they don't get progression of the disease. So with NMO, people get worse because they have attacks of NMO and they don't recover, so they can accumulate disability. So the NMO wouldn't be really in the differential for a progressive disease. One of the things that I find most vexing, actually, in people with progressive disease who tend to be middle-aged to older is the coexistence of cervical spine stenosis. And it's very difficult sometimes to distinguish whether their progressive myelopathy is related to their MS or is from cervical spine disease.
Okay, here's a question that I think I'll take, and that is, are new T2 lesions in the MRI indicative of disease activity? And the answer is yes. So disease activity, as we define it, is either a relapse, a gadolinium-enhancing lesion, or a new or unequivocally enlarging T2 lesion compared to an earlier study. And it doesn't matter when the study was done beforehand. Okay, Claire, any issues with managing progressive disease in pregnancy?
I can't say that I've had that many women with progressive MS pursuing a pregnancy, but I certainly have used agents in and around pregnancy that include those that are indicated for progressive MS. I think that cladribine potentially has an interesting opportunity window for family planning, since it's given as a short oral course. Then clears the system pretty quickly, and generally there's a few years of freedom from treatment, from active treatment, when a pregnancy could be pursued. And then the use of rituximab in and around pregnancy is something that many rheumatologists are very, very comfortable with from their work with rituximab in lupus and other diseases. And we've recently published a collaboration with Riley Bove at UCSF, looking at women who are lactating and postpartum treated with rituximab, and we find really negligible levels of rituximab being secreted in breast milk. So it's something that can be an option for women to be treated, not typically during a pregnancy, but postpartum, when a breast milk supply is mature, that could be, I think, a pretty reasonable option.
Okay. Is there a treatment that targets cognition? And if so, what's its mechanism of action? Aaron?
So I don't really think we've had adequate studies specifically about these respective agents with regard to cognition. A number of the more recently studied agents have included some kind of cognitive assessment, but usually it's been a sort of one test procedure. Most recently, people have used the the symbol digit modality test. Earlier, they used a test called the PASAT, the Paced Auditory Serial Addition test. And a number of these drugs have shown some benefit in decreasing the amount of worsening on those particular tests. I don't really find that very, very highly satisfying information. I think there's a reason to believe that if you have a highly efficacious agent, it might impact those particular functions. But I'd really like to see some dedicated studies with some of our more efficacious agents looking at a more detailed battery of cognitive function.
Okay, and there's a couple questions here looking to get information on comparative efficacy. But as Dr. Miller stated, unless they were in the same study, one really can't discuss comparative efficacy by looking across trials. So I'm going to skip those. Here's one. Is there any data on stopping therapy in progressive MS patients if the lesions decrease and the symptoms improve?
Gosh, if you get symptoms improving and lesions decreasing, I would argue that's a pretty good endorsement that you should stay on that therapy. But there has been I think, interest and work going on to determine when it might be safe to stop therapies in people who have had stable disease and are older. There, I think, large PCORI study going on now called Disco MS to look at discontinuation of immunotherapies. And I believe that the age for that study is 55. Which looks younger and younger to me every day. But I think, it'll be very interesting to see, and various meta-analyses of clinical studies have indicated that our therapies overall work better in younger people. But I think we'll need to really let the data bear it out when it's safe to discontinue. I certainly have done so in my practice, and especially I think of patients who are ready to retire financially, but are holding on to their professional lives because of insurance and issues with coverage of their MS therapies. So this is very impactful, even for people who are tolerating therapy well. The economics of the situation, I think, can be pretty profound.
So I'm sorry I couldn't get to all the questions. I'm going to take one last one before we finish up, and that is, are there any data on combining therapy in progressive MS?
Well, of course, you're the person who should be answering this question because you did the best and maybe the only large randomized prospective trial that looked at comparative efficacy of combining two agents. Unfortunately, now this is getting to be old news, and it used the combination therapy was with an interferon, weekly interferon, and glutathione acetate versus either one of those agents alone. And the trial demonstrated that that particular combination was not better than either of those agents alone. We all, I think, would have an interest in seeing other combination therapy trials with some of our more modern agents. The one group of people that are not too interested in that kind of trial are the insurance companies, because they are not going to want to pay for two drugs. And in fact, there was a trial planned to combine glutathione acetate, to combine teriflunomide with one of the injectable agents, and that trial was canceled, I think, on the presumption by the company that it was not going to be an economically feasible model.
And it was a tough one to study. So I think that moving forward, the combination I'd like to see, especially for progressive disease, would be an anti-inflammatory and some sort of innate immune active molecule. Well, I'm sorry that we couldn't get to all of your questions, but I thank the audience very much for sending in these probing questions. I thank you for joining us this evening. I want to thank Dr. Riley and Dr. Miller for their comments and discussions. Thanks CME provider here for giving us the CME Outfitters for giving us this presentation, Novartis for sponsoring it. So thank you all very much for joining us.